Hello, my name is Dr. Nancy Behazin. I'm a staff gastroenterologist at UT Health Memorial Hermann, the Ertan Digestive Disease Center for Excellence. I'm here to talk to you today about irritable bowel syndrome. Some of the common questions patients have about irritable bowel syndrome are: what exactly is irritable bowel syndrome? What causes irritable bowel syndrome? And what are some of the emerging therapies of irritable bowel syndrome? To start off with, we'll discuss what is irritable bowel syndrome. Irritable bowel syndrome is a gastrointestinal syndrome associated with chronic abdominal pain and changes in bowel patterns in the absence of any organic cause. Irritable bowel syndrome, or IBS, is a challenging diagnosis to make, specifically because it's not associated with any radiologic abnormalities. It's not associated with endoscopic abnormalities, not associated with a reliable biomarker or blood test. Diagnosis of irritable bowel syndrome is made on clinical grounds. However, on occasion, endoscopies are required to be performed, such as an EGD and colonoscopy, to exclude other conditions that may mimic irritable bowel syndrome. IBS is a global problem. It is estimated that 10 to 15% of the general population will experience IBS symptoms. Due to the type of symptoms and frequency of symptoms, this condition is very debilitating for our patients. Now, who does IBS affect? IBS will affect both men and women of all ages. It is estimated to be twice as common in females as compared to males. Irritable bowel syndrome has been defined by the Rome 3 criteria. It's defined on the basis of the presence of recurrent abdominal pain or discomfort at least 3 days per month in the past 3 months, associated with 2 or more of the following: improvement with defecation, onset associated with a change in frequency of stool, and onset associated with a change in form of stool. Symptom onset should be at least 6 months. Now, there are various subtypes of irritable bowel syndrome. There's constipation predominant IBS, what we refer to as IBS-C, diarrhea predominant irritable bowel syndrome, or IBS-D, mixed irritable bowel syndrome, or IBS-M, and unclassified irritable bowel syndrome, or IBS-U. Some of the symptoms in IBS patients may be intestinal related, but there are also extraintestinal symptoms you may be experiencing. Intestinal symptoms that are common complaints in IBS patients are constipation, diarrhea, bloating, nausea, and epigastric pain. Some extraintestinal symptoms IBS patients may experience are headaches, backaches, impaired sleep, chronic fatigue, pelvic pain, and mood changes. Inflammatory bowel disease and irritable bowel syndrome are two vastly different diseases. IBD is not the same as IBS. However, IBS symptoms are common in patients with inflammatory bowel disease. About 33% of patients with ulcerative colitis, which is a type of IBD, have IBS. About 42% of patients with Crohn's disease, which is a different form of IBD, also have IBS. Now, what causes irritable bowel syndrome? There are a variety of mechanisms that have been implicated in the pathogenesis of irritable bowel syndrome. Abnormal intestinal motility, visceral hypersensitivity, low-grade inflammation, genetics, and stress have all been implicated in irritable bowel syndrome. Let's talk about abnormal intestinal motility in irritable bowel syndrome patients. IBS patients may complain of diarrhea or may complain of constipation. Diarrhea may occur in IBS patients from increased high amplitude propagated contractions, enhanced gastrocolic response, enhanced rectal sensitivity. Constipation may occur in IBS patients from increased segmental contractions, which are non-propagating, reduced high amplitude propagated contractions, and reduced rectal sensitivity. Visceral hypersensitivity has also been implicated in IBS patients. This refers to a heightened sensitivity of the intestines to normal sensations. There are various receptors present in the gut wall, and these receptors send signals via neurologic pathways to the brain. Several studies have shown that IBS patients have a hypersensitization of the neurologic pathways. For example, IBS patients have been shown to have increased awareness and pain caused by gas and distension compared with healthy patients. There may also be local inflammation in IBS patients. Inflammatory cells such as mast cells and activated T lymphocytes are increased above normal in the mucosa in a subset of IBS patients. Lymphocytic infiltration of the nervous system of the gut or the myenteric plexus has been seen in severe IBS cases. The cause of this inflammation is not known, but infections, altered gut microbiota or gut flora, bile, or food may contribute. There have been food triggers implicated in IBS. Many patients report IBS symptoms to exacerbate with certain foods. About half of patients with IBS have symptom improvement with elimination diets. Subtle gluten intolerance may be present in some patients with IBS who do not have overt celiac disease. Fructose and sorbitol malabsorption may contribute to IBS symptoms as well. Abnormal colonic flora, or microbiota, and small intestinal bacterial overgrowth have been implicated in IBS. Colonic flora could be abnormal in a subset of IBS patients. This may cause increased colonic fermentation, production of gas, and development of symptoms. There is also a high prevalence of a particular condition called small intestinal bacterial overgrowth in IBS patients. Specific testing is required for SIBO, or small intestinal bacterial overgrowth, which can be performed at a center of excellence such as ours. Central dysregulation has been shown to be present in IBS patients. Visceral afferent signals from the intestine reach the brainstem and thalamus and are occasionally consciously perceived. Functional brain imaging shows alterations in brain response to visceral stimuli in IBS patients. In IBS patients, there is greater activation of the mid-cingulate cortex, an area which processes visceral signals. A number of psychological factors have been implicated in IBS symptoms. The most common psychiatric conditions that coexist in IBS patients are depression, anxiety, and somatization. In animal models, stress leads to the release of corticotropin releasing factor and acceleration of colonic transit. In human volunteers, stress changes intestinal secretion and permeability of the intestines. Sustained stress could be important in the onset and persistence of IBS. Genetic factors have been shown to play a role in IBS as well. There is likely a small hereditary component of IBS. There is clustering of IBS in families, and studies performed in twins show greater prevalence of IBS in monozygotic twins compared with dizygotic twins. A patient with IBS-like symptoms and alarm symptoms needs further testing. Some alarm features needing further investigation in patients with IBS-like symptoms may be present in the history we take from the patient, or may be present on physical exam. Some alarm features that we may elicit on history taking are shown here. Blood in the stool, family history of colon cancer, IBD or celiac disease, fever, nighttime sweats, chronic diarrhea, dysphagia or trouble swallowing, recurrent vomiting, severe chronic constipation, travel to areas endemic for infections, and weight loss are some alarm features that need further workup. Physical exam findings such as abdominal masses, arthritis, dermatitis herpetiformis or pyoderma gangrenosum, which are skin findings, blood on rectal exam, signs of anemia, signs of intestinal obstruction, intestinal malabsorption, or signs of thyroid dysfunction are some alarm findings on physical exam that warrant further investigation. Celiac disease occurs at higher rates in IBS-D patients. Routine testing for celiac disease is recommended in patients with diarrhea-predominant IBS. There is a 7-fold increased risk of celiac disease in patients with IBS-D. What are potential therapies available to treat patients with IBS? There are dietary changes. Diets low in FODMAPs, which are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, have been shown to improve IBS symptoms. In one study, 13 of 19 patients randomized to a low FODMAP diet had adequate control of their IBS symptoms at 4 weeks. Dietary changes should be made under the guidance of your gastroenterologist and nutritionist who are adequately trained in a low FODMAP diet. Other treatments for IBS patients may include interventions that change the microbiota or the gut flora, such as probiotics or antibiotics, antispasmodic agents, peppermint oil, loperamide, antidepressants, psychologic therapy, serotonergic agents, prosecretory agent. Now, management of your IBS will include your gastroenterologist and nutritionist. Management may also include your PCP, psychologist, or psychiatrist. In summary, IBS is common and has debilitating symptoms. The cause of IBS is multifactorial, with abnormal intestinal motility, visceral hypersensitivity, low-grade inflammation, food, genetics, altered microbiota, and psychosocial stressors being contributing factors. Management of IBS requires a multidisciplinary team, and this is to implement some of the new dietary changes as well as medical therapies that have been proven to be successful in IBS patients. I thank you for your time. For appointments, you may call the number on your screen or visit the website on your screen.